Hey everybody, this is Erica Meloe, and welcome to episode number 48 of Tough to Treat. Oh my gosh, we are 2 away from 50. It's crazy. Time flies. Oh my God. Susan and I want to thank everyone who's left us a testimonial / review on wherever you listen to podcasts. And it's really important for us and for anybody who does a podcast to have a large number of testimonials and reviews for anybody to find us in the podcasting world. And if you have not subscribed, please do so. We would really appreciate it. And thank you to everybody who has left us a testimonial. And thank you in advance for the people who will do so. Thanks. This episode is a patient of mine who I've treated on and off for many years now, on and off for back pain. And it comes and goes. And I hadn't seen her for a couple of years. And her main issue at this point was thigh numbness. Common, right? People get thigh numbness, and she's rubbing the thigh, and is it really the nerve? Is it? Ultimately, the nerve is angry because it's her thigh is numb, but it wasn't really the nerve that was causing her problem. And Susan and I go back and forth and clinically reason how I assess this patient and how I will progress her, because I am still treating her as of this recording, and it does not just go to the quad or the leg. And when someone's rubbing their hand up and down their thigh and you think it's not their thigh, you need to disprove that theory. Because if they continue to rub their thigh and you don't touch their thigh, they will think it's their thigh. Anyway, enjoy the episode. Bye. Hey everybody, this is Erica Meloe and Susan Clinton, and welcome to Tough to Treat. How are you, Susan?
I'm good. How are you?
I'm good. And as we're recording this, it's the day after Memorial Day here. So it's hope everybody had a nice long weekend. and
Yes.
Here we are.
And enjoying some beautiful weather in the Northeast.
I know, my God, we actually had 3 days of sun, no rain. I was stunned.
I think summertime is finally upon us.
I know. It usually is quite rainy around this time of year. It's actually going to rain here today, but we never really have a Memorial Day free of rain, and I think this was a good one. So anyway, you want to get right to it?
Yep.
Okay, so this is a patient of mine who I am currently seeing, and she has some history. So I saw her last year in June of 2018. I'm going to briefly go through that because it is somewhat relevant, but she's coming in with a different issue this time. And she is in her mid to late 30s, and she is an office worker, a medical office worker here in New York. I've treated her before on and off for low back issues over the many years, and she's very hypermobile and always feels shifted, and which is what she came in June of last year with. Left, to quote her, left low back spasm, and she feels shifted. So the main issue with her is getting dressed, walking. She couldn't go into left hip flexion. This is, stretch. She's the one that stretching, she tries to stretch and it makes her feel better, coming off our last podcast. This is the one who, I need to stretch all the time as well, not generally giving her long-term relief. So just in a nutshell, I did treat her for a period of time for probably 3 visits last June, on and off. She's needed some stability. I mean, at the end of the day, she was overusing her hip flexors, overusing her quadratus lumborum. I ended up doing some stability work and doing some taping and sort of pelvic support with her. She got better. But that is one of her issues. She's on and off low back, thoracic low back pain over the years. And she was fine. She came back to see me in November of last year and complaining of right quad numbness. And she had it she said she had it a few years ago. Never mentioned it to me because I think it just always went away, and it did. This time it's not going away, and she was putting her hand not sort of like on the rectus femoris, more on that lateral sort of vastus lateralis, partly, that anterolateral thigh, obviously above the knee. And years ago it would go away, and now it's been on and off. on and off for the past few months. She has a history of knee issues bilaterally, which she's had several surgeries on them, like an ACL years ago. She's had some straight scopes on them. She gets Synvisc injections generally every year for them. And that's not her. She was not complaining about that. And over the years, when I did see her for her back, we had to adjust her ergonomics at work because she would sit. She's in the medical field. She would sit, she would stand, and she'd have to turn her body in different ways because of either treatment tables or equipment she was using could not be moved. So we had to move her. So another issue, which I thought was somewhat interesting, and I'd love your opinion on that at some point, she did have surgery, I would say probably 5 years ago, what I want to say, for some uterine fibroids, significant actually, to the point where she was somewhat hospitalized for that. And she never really had any issues after that, but that sort of, I had like not a red flag, but a yellow flag in my brain because of that. So I don't know the extent of the surgery. I wasn't seeing her at the time. I think she's kind of blocked it out of her mind, to be honest, but it was for fibroids, but a big surgery. And let's see what else. No incontinence, no bowel or bladder issues at this time. She never really complained of any of that. But the main issue for her was standing and walking. That's where she sort of felt this numbness. Driving, she didn't really feel it. She'd put the heat, she drives into work, she put the heater on in the car. That made her feel better. Sitting made her feel better. Rolling on the half foam roller on that outer quad made her feel better. So I'll stop there, and you let me know if you have any questions or have any thoughts before I get into what I found.
Yeah, so we've got an individual here that has all of the things that you see with the hypermobile tissues and joints and things like that. Long histories of back pain, other kinds of issues too with knees, multiple surgeries, things like that, right?
Mm-hmm.
We're looking at this and then hearing the story of the uterine fibroids and kind of just the transient chronic pain that she's had. And it makes me, well, first of all, whenever I hear about uterine fibroids, I know we have estrogen dominance. So her hormone system is wacky, and that's a huge problem. Did they take her uterus out? Did they do a hysterectomy?
No.
So, okay. They probably have her on some sort of synthetic birth control pill.
I'll ask her. I don't know if she is, but I actually think she is, actually.
Mm-hmm.
I will ask her.
Yeah.
Sorry, go ahead. Any more?
That's only going to make the situation worse. That's a whole nother story for a whole nother podcast. But if she's estrogen dominant, she can. There's some things that she can do. What is she doing for exercise?
She spins. I spin with her, actually.
Okay.
Pretty.
Does this get worse with spinning?
It sometimes and sometimes not. It's very random. It's not all the time.
Okay.
Yeah, I will tell you, if it's bothering her and she gets on the spin bike, she does feel worse after.
Okay, so if it's already there, spinning makes it worse.
Yeah, but it generally doesn't bring it on, no.
Yeah, but so it's not it's just an aggravator, not the initiator.
Correct.
Okay, all right. So does she do any other kind of exercise?
No.
So she might look at doing some balance.
Yep.
In her exercise program, picking up a quieter routine besides just the spinning, so that she can get a bit of balance into her hormone system. If you've got somebody who's estrogen dominant and they're going Mach 5 with their hair on fire all the time, it's only going to keep the system. It's going to not allow the system to produce the progesterone like it should, right. And so that can be a huge problem with the pain and the just the overall issues system wide.
Yeah.
So picking up another, I'm not saying don't spin. I'm saying don't just spin.
Right.
So if she wants to do something quieter like Pilates or yoga or, there's a bunch of different stuff out there. That would be really good for her to do to get some balance in there for sure.
Yeah, I agree. In the past, when I work with her on her back, she definitely did better with, resistance work for sure.
Yeah.
And, really
Yeah,
support.
these folks need to be loaded for sure. So,
Totally.
so the spinning is great, but, she could pick up just not with really loud, crazy music, but, a nice weightlifting routine.
Yeah.
Get her going on some of those things too, to just help her, overall system. And that could be kind of the balance between the spinning for her as well. So just something different that her system can do that's not going to rev it up to the top speeds all the time.
Yeah. Yeah. I would agree.
But anyway, quad numbness, an interesting thing. So neuralgia paresthetica is
That's
one
what
thing
we
that comes
thought.
to mind,
Yep.
but also thinking about her lumbar spine and all of the stuff that she's having, I'm wondering if she's got some hypermobility in that thoracolumbar junction or
Yep.
hypomobility.
Yep.
And is that driving some of the symptoms coming around?
Mm-hmm.
Because it could be kind of an ilioinguinal overflare, and it could be just a super sensitive nervous system. It's
Mm-hmm.
kind of picked up. It doesn't sound like it's much of a femoral distribution unless you're thinking that anterior branch of the femoral nerve, right? Which is
Yeah.
the one that the neuralgia paresthetica is. But
Yep. Yep.
it's interesting that that she's got some knee issues too. So what did you look at?
So what I did was because of her history with her lumbar, I basically just had her do forward bend, made it feel better, of course, right?
Mm-hmm.
I said, do me a favor, just stand there and I always tell patients, just pretend you have to go to the bathroom and there's no bathroom, okay? And just do a gentle lower abdominal pelvic floor, just easy. And she's like, oh, I feel better. I'm like, of course you do, right? But so then I said, just do a back bend, which of course made it worse. Is that because she's stretching the anterior structures of the hip, or because clearly she's compressing something in her lumbar spine? Given her history, I was, going to go for the latter, the lumbar.
Mm-hmm.
So I tested femoral nerve. I did the pro knee bit. I did the femoral side slump. I tested everything. I did test her. I did like a reverse pro knee bend. So I really wound up, instead of doing a slump, I did like a completely extended lumbar spine and did the femoral, just pulled the pro knee bend with full hip extension. Of course, that's going to flare her up, but that's not a femoral slump. That's a reverse. Not sure what to read from that, except that perhaps she is getting something into her, that something is in her, is happening in her lumbar spine. I don't know why I did that. I just felt that because extension always sort of made her worse, and sitting generally is better. I checked her slump. She was fine, which that wasn't surprising. But when I did take her into she was in sort of sideline left. I had to really arch her back completely straight, and then I took that top leg and brought it back into pro knee, but and then that flared the numbness up. It's not a real test, but it's something that I just made up at the time.
You were trying to see where you could aggravate the tissues. Did you do any prone push-ups, prone back extensions?
I did, and she felt okay with that, which is surprising. But she's the kind of person that I would have had to wound up all the way up into full cobra and do a full back bend, I think, to really flare her up, which I didn't do.
Mm-hmm. It's not surprising to me that it wasn't bringing anything on, because I see that a lot in these types of patients, that they can't stand and bend backwards, but when you get them prone on the bed, they can push all the way up. It's
Yeah,
kind of a hallmark sign of
unloaded.
that hypermobility kind of thing.
Yeah,
It goes on. So it takes kind of some extreme motions to get these tissues wound up. What is she doing during her life at work and during her life that she gets into these positions?
in terms of I'm walking and standing. That's the only thing I can think of, is because she's not a dancer. She's a medical worker. So she sits a lot. She, gets down on the floor with the children, actually. She's reaching, things like that. It's like not a lot of extension or hyperextension. However, what I thought was interesting, I sort of poked around the front of her thigh. This is in November, mind you, okay?
Uh-huh.
All right. So I went into the quads. I went into like the adductors, deep in between the adductors. She went through the roof. And I said, oh, wonder what that was all about. And I'm thinking this certain, that something with the surgery, but that's not, that's not my expertise. So in terms of what happens in the pelvic floor when you have those types of surgeries. So I said, well, that could be possibly, a reactor, basically, a muscle that's a reaction. It's just sore there for some reason. Or it could be something, what's the word, a contributing factor or a significant contributing factor. But I don't think it is. So anyway, so she came back so in that particular visit, I didn't really treat. It was a long one. So she feels better with warm heat on her thigh. And I'm like, well, it's getting your blood flow. That makes sense. I gave her some stability work, pretty much what I had done in the past, because I felt that based on that, I did some, the PAAOMPT on her lumbar spine, and she's hypermobile. I didn't particularly think I was gonna glean anything from that. So the issue now, and I'm just going to fast forward because I basically gave her some stability work. She came back 3 weeks later. She basically said the numbness was improving. Okay. She probably wasn't doing a ton on her own. I think it was just time and maybe some of the stability work that I gave her. She said now it's localized to a small
Before you go into that, I just have one more question I want to ask.
Yep.
So you said in her exam that she didn't have good left hip flexion.
No, she had a problem doing that.
Yeah, so it was problematic. Did that bring on the symptoms?
No.
Okay, I'm just wondering, since you said she gets on the floor with children, if we've got a little bit of an entrapment issue that flares up when she straightens up out of hip flexion, but could be because she sits all the time.
Correct.
She gets down on the floor in hyper hip flexion.
Correct. So interesting you say that, because when she came back in December, that's what I thought it was. So, because I hadn't seen her, and these people, they come and they go, and we could do a whole podcast on patient compliance, but that's not the issue. So, it's ridiculous. I feel like you start all over again. So I repeated some of her tests. The backward bending, lumbar back bending was still positive. I had her, she said the walking was getting to her. So I had her stand with that left leg forward, right leg back. It's right numbness. And I really had her stand in a long, long stride. So as she would like stretching that right side. And it really flared the symptoms up. Okay. And so I said, just try to push your heel into the ground a little bit, use your hamstring, use your glutes on that back leg. And it took a lot of the symptoms away. So every time she starts to use muscles, quote unquote, she can take her symptom away. The key is, what muscle groups do you treat, right? I did test her hamstring strength. It was pretty weak. It was a 3+, but not surprising. She's got knee issues on that side. So in that particular visit, I did work on her hip because I felt that there was some impingement going on, because she was getting more on the floor with the kids. And I said, you know what, let me just do this. Because 3 weeks had passed. She was better, but she wasn't really 100%. And she's the kind of person she's changing all over the place, and she's really hypermobile. So I did do some work on the hip. I gave her isometrics. I mobilized the hip. I did some soft tissue work in the iliacus, and did some easy nerve glides. They were not provocative. Okay, but I did. And then she went on her merry way. Okay. And then I gave her, her basic home exercise at that point was, when she was on the spin bike, I wanted her to pull up with the hamstring instead of pushing down with the quad, pull up with the hamstring at the bottom of the pedal stroke. I gave her some seated hamstring isometrics. And the quad stretch wasn't really making her better. I told her she could do it. It wasn't making her worse. So if you want to do it for short-term relief, you can. Now, this is where I'm at now. So she goes, okay? Doesn't come back till April. So we're looking 4 months here, right?
Okay.
And I'd seen her on and off in spinning, and she was getting better, up and down, up and down. Started acupuncture, was making her worse. So this is where I'm at now, and this is where I need some issues, because kind of all over the place. She basically felt, so she came in to see me, the numbness was back, and she's like, my foot's a contributing factor. I know my foot is. I'm like, oh my God, here we go. So, and it wouldn't be surprising if it was part of the issue, knowing her. So what I ended up doing, I rechecked everything. okay? Her hip flexion at that time was only 90 degrees on that right side, okay? And when I left her when she left me back in November, December, she was full. Okay, so something had happened in those 4 to 5 months. Her hip flexion was 90, the same objective issues. Lumbar forward bend was fine, backward bend was positive, putting that right hip, that right leg behind in a stride stance definitely made it worse. Nothing changed, okay?
Except the hip flexion, right?
Correct.
And
so
was she not flexing her hip because of pain, or because you just couldn't flex it?
I couldn't flex it. I just think there was so much tone in and around her hip at that point. So what I ended up doing, because she was so adamant about the foot, I'm like, I got to do something to the foot to make her believe or not believe that the foot's the problem. So I ended up in backward bending. I said, let's just do, because that's the most provocative movement. I ended up correcting her foot. I put her foot in subtalar joint neutral, tried to, sort of optimize the talus, quote unquote. So I basically held her foot so she couldn't compensate. For some reason in backward bending, she was doing something funky with her foot. I could not see what it was. So I said, let me just neutralize your foot. Let me hold your foot here and do a back bend, and let's see if your symptoms go away. And lo and behold, they did. And I was like, God darn it. I was like, you had to be, So for me, because I'm so biased towards her lumbar spine at this point, because she's had the issues, she was getting better. So she wears certain shoes. She turns the numbness on. She takes certain shoes off, certain more shoes that are stable.
Yeah. So what shoes bring the numbness on?
Her sneakers.
Okay.
These Nike Air Max and these Nike ones that are like completely, I've worn them. They have no stability at all. They're completely, they feel great. And I said,
is she foot gripping?
Yes.
Yeah.
I said, you have to stabilize yourself.
This is kind of course, so she's probably, when you were back talking about the pelvic floor too, she's probably running with a pelvic floor that's overworking as well. That's usually the case that I see in this.
Mm-hmm.
It wouldn't surprise me because of the fibroids and the estrogen dominance. She probably has some pelvic pain, some deep pelvic pain. So you might ask her if she's got pain with insertion. Is she using tampons? Does she have pain at the doctor's office? She could have just an over-gripping pelvic floor without pain too. So it doesn't have to, but that's any urinary urgency too can, because that kind of goes hand in hand with an over-gripping foot.
Yeah.
And over-gripping hands a little bit. So did you start working with the long yoga toes and?
Yep, exactly. So I said, you keep doing what you're doing. I ended up doing some work on the foot. Exactly. Yoga toes. I tried to release the bottom of her foot. I said, put your foot on a dumbbell and roll on it to release the bottom of the foot. I just did some.
Those air balls work really good too, because they can roll those all around. And
exactly. Yeah. Any massage ball, air ball, dumbbell, whatever you have. I did not tape her because I think she had some issues prior. She's obviously also very allergic. She's got a lot of allergies. Yeah. Okay. She carries an EpiPen. So no, I forgot to mention that. She has a lot of allergies. So I did not tape that. I did not tape her. So I worked on her foot. I rechecked her hip flexion at the end of the treatment. It was full. Her nervous system adjusted. I'm not sure. All I know is I did very little work on the hip in that particular treatment session. That was in April, end of April of this year. Okay. And hold on. I want to look at my notes. Give me 1 second. I want to make sure I didn't miss anything.
Did her hip flexion get better after you worked on her foot?
Yes. So in my last note, I'm just looking here, I did give her a couple things to seat her hip. So when I had her on all fours and just do like the Shirley Sarman sit back with that right, so she was fine. But then when I had put her right hip into external rotation, like Sarman does, and have her sit back, her symptoms were worse.
Okay.
On her hands and knees. That was the only thing I forgot to mention. I felt that she was really overstretching. I felt the stretches were making her worse. And I mean, it was just crazy. So I told her to stop stretching. But that's basically it. So April 20, so that's April. 2 months go by. Here we go again. I don't see her. She said she was I saw her in June. Okay? Not June, I'm sorry. We're already in June.
May. No, we're in May still.
We're in May. So, hang on. I'm getting myself here. Hold on. Yeah. So basically, she came back to see me and she was improving. She felt that the footwork had helped. So I'd given her some just foot control, because I felt that when she was walking and that right foot was behind her, she was pushing off on a foot that was non-optimal and it could have been aggravating the hip. So I gave her foot control. I gave her a lot of just basic, you know, typical seated heel raises, heel toe, all your foot control stuff that we learn, right? And told her to stop stretching. And she was getting better. And she ditched all the shoes. And I saw her, so now we're looking at 3 weeks later, which is last week, and her symptoms were better, but she was complaining of back pain now again. And I was like, here we go. It was just one thing after another. And I feel that the numbness is improving. However, it's still there and her back pain is coming back. So that's where I'm at. And I'm going like berserko because she's the kind of person, or any hypermobile patient, they're going to have issues in various body parts.
Right.
And I know the thing is, I treated her on and off for years. I'm trying to get out of my bias of the lumbar spine because that's always been her issue. So I was open to the foot and I was open to treating the foot because she was adamant that it was helping, that it was part of the issue. And I would agree, it's probably part of the issue. Is it the whole issue? I don't know. I want like your thoughts because that's where I'm at with her right now.
Yeah, because what you're looking at is somebody who's just got a systems, a problem system wide. And I love the way that you were actually treating her and treating her gait because you were getting at the entire system that way. I would, if I were you, since that was producing some favorable results, I would stay the course because now that her hip is being controlled better with her foot, her back is going to not be as controlled. Probably she's going to, how these types of patients move up and down the chain all the time.
Yep.
I would stay the course and pull the motor control exercises into her trunk better, and give her that opportunity and keep doing what you're doing with the foot and the leg. Just add the motor control piece for the trunk on top of it. So work with her in those positions where you were working on that foot control and dynamic foot, and just add you can do things like add exhale, to pull in her deep, deep motor control system, the deep postural muscles. And, she can actually work off of strong feet to do some of the motor control exercises you want her to do with her trunk, and see if you can pull that whole system together that way, to give her some support.
Yeah, I would agree. I'm trying to think. The footwork that I did give her was the self-release, and then I gave her like different phases, because the gait she's just not pushing off. So I gave her seated heel raises to start really easy, walking toe heel, backwards walking toe heel, and then heel toe, and then I gave her standing, sort of holding on to something with the right leg behind, sort of push off, but do it in a mirror so you can see your foot, things like that.
Yep.
So that's what I've given her. And
you can even progress that up into one-legged stance.
Exactly. That's where I'm going next.
And fingertips on the wall, and she can work on some heel raises.
Totally.
Both, and then maybe start working on heel raises on the right, but then bring that exhale on and get her deeper muscle control system working with it. So that she can have that motor control of the pelvis. It's kind of an Eric Franklin technique, but I always put my hands on either side of their pelvis so that my fingers are coming straight off of their ASIS, pointing towards the wall or the mirror, and I'll tell them those are their headlights.
Yep.
And they want to keep their headlights on the road.
Yep.
So if they lift their leg up too much, the headlight, if the hip starts to hike, it's again, some of the Shirley Sarman work too goes along well with motor control, because she'll talk about the hip will hike or the whole pelvis will hike up, to lift the leg up, and it doesn't need to. The leg should be able to lift up freely without the pelvis lifting up. So probably what's happening now is you've got the pelvis leg better, but now her back is still discoordinated with that whole system.
Yep.
So now you can really work on knee flexion with the pelvis staying still, and the back staying still and just allowing that knee to come up and standing on one leg and, doing those push-ups and things like that.
Mm-hmm.
But, bringing that breath on to really kind of help her with her deep muscles.
I like the exhale. That's
Yeah.
something that I often forget.
Yeah.
So I was actually just reading an article about that.
Yeah.
Yeah. Exactly. Blow as you go. I like that. Yeah, there was some, I was reading an article. I think it was in the section on women's health journal about it was a case study about something I don't remember, but they referenced Paul Hodges' work as well with regards to diaphragmatic breathing and turning on transversus. So that's a great idea. So that's what I'm doing. But what do you make of the all fours into external rotation, flaring that up? Think she lost control of her lumbar spine, or do you think that's coming from the hip?
Or both.
Yeah, right.
I think obviously sitting on the floor is not a good. I think part of this is all coming from sitting on the floor, because when we talked back, about kind of what would be impinging and causing these problems like she's having, and oftentimes it's hyperflexion in some of those positions. So if she's probably sat on the floor her whole life, crisscross applesauce, and never had a problem because everything moves well. But at some point, if things are not moving so well, they keep kind of just sitting in the same position, and so what I would do with her is get her on the floor and have her sit crisscross applesauce and see what her hip does. Yeah. And then I would take some folded yoga blankets or one of the yoga blocks or whatever you have, a stool, folded towels, any of it works, and get them under her pelvis and lift her up until you can get that to not hurt. Yeah. Yeah. Or not flare up. So that's what I would do with that, and say, this is the position you're going to need to be in for a while. And it may be kind of high. It may be 12 or, 14 inches that she needs to sit down on the floor, with the kids, to do the things that she needs to do, but to really also open her hip up. Yep. Yeah. So it's not being in that really tight compressed position. Yeah. So I think that what you saw there was really good and telling, but she's not going to be doing that a lot. She's going to be sitting a lot. Right. And sitting and leaning forward. And so there you go. You're taking her right into that position just the opposite way. Yeah. Instead of closed chain, you're going open chain into it. Yeah. And, with the trunk doing the movement. And so that I would really spend some time looking at those positions and see if you can't get her in some better positions that don't, or some different positions, not better, but different, that don't flare her up. Right. And so in terms of the pelvic, I have two more questions. So in terms of the issue with the pelvis, the fibroids, is that, she's like, it doesn't bother me anymore. Like she poo-poos it a bit. So I'm just wondering how to gently, do I even go there with her anymore? Or, because she's of the belief that it doesn't have anything to do with it. Well, you got to kind of go with where they are. Yeah. The only thing that I would ask is she's not having any symptoms. She doesn't feel heaviness. She doesn't feel heaviness in her vagina. She doesn't have urgency frequency with urination, which is, that's usually a sign of a overactive pelvic floor or an over-recruiting pelvic floor. She's going to, if she's pooping good, then that's good too. A lot of people don't realize they're constipated, even if they have bowel movements every day. That's something that probably needs to be broached with her, because if she is estrogen dominant, which I can't imagine that she's not, the only way you're going to get rid of that is to get rid of the constipation, or to balance that a little bit better, because that's the only way we can move estrogen out of our body. Oh, interesting. I didn't know that. Yeah, through the bowels. Oh, wow. That's wild. Yeah, so that's why constipation is a huge problem with people with trunk trunk pain and those other kinds of pains, because the buildup of the, they're not moving, they're not detoxing the hormones out like they should. Oh, interesting. So, fabulous. So those would be some questions that I would ask. I would ask her, I would just ask her and say, look, if it may not be anything around your fibroids and that kind of stuff, but you have a musculoskeletal system in your pelvis, and if it's not working quite as well as it should, we probably need to take a look at that at some point to see, because we're looking at your foot, we're looking at your hip, we're looking at your back. We need to make sure we're getting everything in between, coordinated all the way up. And it may be, it may be a piece that could be very helpful And with all of these other things that you have, with your highly allergic system, needing to carry an EpiPen, the estrogen dominance, because you don't get fibroids without estrogen dominance, that all goes together, with this. And that's why the exercise, you need to do some other exercises besides the spinning, because you want to do some things to balance your system out so that your system has a chance to come down as well as go up.
Yep. I agree.
I agree. Things like that.
Yeah, that's great. She expressed an interest in Pilates, and I was like, I'll go with you. I'll take a class with you.
Yeah, do it.
I've done it.
Yeah, the loading and the stuff would be really super good for her.
Yeah. So in the past, she's done really well with the stabilization for her standing, for her low back. And so I'm just wondering if I'll just progress her through a basic, stabilization, try to incorporate that more with the foot. I like because she won't do a bazillion exercises, and that's just not my style. So besides the exhalation with the footwork, and I can just have her doing some cueing with transversus. Is there anything else that you know of cue-wise? Because I don't want to start giving her bent knee raises, because I've done that in the past with her hamstring, and that's helped, but she's not going to do all of that.
Right.
So I want to incorporate more into functional movements.
So I like what you were doing with walking, because she can do that with walking.
Yeah.
I wouldn't give her, I think my personal bias is to not have people try to cue a deep muscle, but to automate it with exhale. Kind of just like blowing through the straw.
Okay, that's great.
Bring all of the muscles on so they automate better.
Yeah.
And she can do that when she's, at work. If she's standing at work, she can stand on one leg. She can stand on the other leg. She can do the breathing while she's at work. She can actually do a forward sway if you want to get the gluteal muscles and the deep soleus muscles to actually start to work. And she can think about her toes getting longer rather than tightening up as she sways forward at the ankle. So you can have her do some of those so she can sway. She can stand and sway in a lot of different positions.
Yes.
And that's great for the feet and the hip and everything. And then she can bring the breath on with it. Yeah, so that can be pretty functional for her there. And then I would really make sure, I would really, with her, I would really get her on the floor and figure out how you can get a different posture in sitting.
Yeah, I will. Yeah, I absolutely will do that. I like the swaying, because that'll work. That'll work the.
And she can do that with one foot in front, like in stride.
Yes.
Too. So you can, you can just kind of incorporate that to those things. But I would get her to some loading activities for sure. And if Pilates is going to do it for her, that'd be great. Yeah,
I've been doing the stride, but I've not been incorporating the exhale and that. So that's a great idea. Yeah. That's amazing, because I've been doing but all foot. Because that's where I was at that point, and
but you've got that piece now.
Yeah.
So
I've got that down.
You can just pull that in. The other thing she can do is when you have her in stride, have a look at where she is, and if she's in hyperextension, then have her just bring her thorax over her pelvis a little bit.
Yep.
Kind of just bring it forward, or bring the whole trunk just a little bit forward.
Yeah.
And get her out of that hyperextension.
Yeah.
And then with the exhale too, and then she can kind of start to realize, all the time I keep going back into this hyperextension, which brings on her symptoms. I need to stop doing that.
Well, it's interesting, because in spinning class, I do see that they do like 1, 2, 3 pound weights, and she can't do more than 1 or 2 pound weights. I'm like, that is obvious issue. There is this huge strength hole in her pushing her tricep muscles. So there's definitely a stability issue there for sure. Yeah. And I like the swaying, because she could practice that at work. Yeah. And the issue is, I will question her on a lot of the pelvic health, the pain with insertion. I don't know those answers. Those are things I don't normally ask, and we all should. Yeah, and I have to get more. I ask about the obvious incontinence, things like that, but I don't delve deep into the women's, into that, because that, I think it's just my bias, but given her history, I think it's something we should just ask everybody, and it's going to take for me some time just to get that as part of my routine interview. But for her, I believe it's definitely important. I really do.
So we can make some referrals for her.
Yes, right. Totally. Yeah.
I will. For that piece.
Yeah.
If she's interested in pursuing it, so.
Yeah, for sure. I will find out.
Line it out like you do with the systems, that it's part of the system. you know, and
Exactly.
we're only good as our weakest link in our system.
Yeah. Yeah. No, I
So
agree.
if we have something that needs to be shored up or coordinated in, you know, we can do that.
Yeah. Yeah.
For sure.
I think,
But using the breath will help.
yeah, what's been interesting though is the spinning has really helped her knees. She hasn't had much of a knee issues bilaterally for quite some time. And I think it has helped her overall because her feet are clipped in, her hands are on the bike. She's you know, not going anywhere.
It's
she's
great,
stabilized.
but it's all she's getting for exercise, so she's never getting out of that posture.
Yes.
And she's in a forward flex posture on the bike, and it feels good.
Yeah.
You know,
Yeah.
so,
Yeah.
you know, but she has to start loading herself in some other positions and directions for some variety.
Yeah, I agree.
So the Pilates may help, especially if she would go and do that a bit.
Yeah, I agree. Well, I will report back on her because I am seeing her this week.
Yeah.
And that's where I was. I wanted some input on her because you, as a therapist, you see people for many issues over the years, but she's been a consistent lumbar issue. She came in with the numbness, which I had never treated her before. I didn't think it was neuralgia paresthetica. It would have gone away. It was too reproducible with lumbar spine movements. But then when she came, but the issue is there were long periods of time where I didn't see her. And I felt like every time she came in, I had to go back to square one. And that's the problem when you get non-compliance, right? So now I'm like, you need to come in every week or every 2 weeks. You just have to come in so we get some good attendance and compliance. So she is now. So I will report back and let you know.
Sounds good.
Sounds good.
You're welcome.
All right. Thank you, everybody. Hope you enjoyed it.
Yes, we'll see you on the next podcast, and be sure that you go into iTunes and Spotify and wherever else we are on, Stitcher, and leave us a review. We appreciate that very much. Thank you to all of those who have reviewed us. We really appreciate it, and it helps others find us. Thank you.
Thanks a lot. Bye.